So without further ado, thank you guys for joining. We've got another installation of ACEP's virtual case conference. For those of you that weren't able to join us last month, we kind of switched up the style in which we're using this time to present fellows' work, and that we're transitioning away from spending the whole hour talking about a single project, which is great and awesome, to expanding the platform a little bit to highlight the work that multiple fellows at a program are doing. And the goals here are to really showcase the work that the program is doing, but also shed a little bit of light and transparency on what does a curriculum at a CI fellowship look like at Stanford versus Hennepin versus Metro Health? Because we are a relatively new specialty. And on top of that, I think the field is so broad and so dynamic that a lot of us have very different experiences. And so I hope that this is kind of a conduit to having having more open conversations.
Yeah.
And can you mute your mics, please, if you're just joining? So hopefully this is a conduit to having more open conversations around what
yeah, so it sounds like it might not
CI
work
fellowships across the country look like. And we get to do it on Zoom, which is always fun. So with that, I want to introduce Wui, if I'm pronouncing that right. And
yeah, that's why it's just like video game.
Yeah, and his cohort of fellows at Stanford who will be presenting some of the work that they've been doing over the past couple of years. So with that, I will hand over the mic to Wui and let him introduce the other fellows that he'll be presenting with today.
Great. Hi, everyone. Can you guys see my screen okay?
Yes.
Okay, great. Yeah, thanks for joining the conference. My name is Wui. I'm a pediatrician and second-year fellow at Stanford. So I would just spend the first couple minutes to tell you a bit our fellowship program. And then I will let my co-fellows to introduce themselves and let's talk about our scholarly work. So from a high level, these are our program characteristics. It was born from a hospital-based applied CI department, but at the same time, we are associated with a very strong academic informatics department. So we get to work with both applied clinical informaticists as well as academic faculty who do informatics-based research. We also get to interact with people from the industry through elective rotations or lectures. So in terms of the structure of the program, all the fellows spend the first 6 months doing the required rotations at each training sites that are listed here. Stanford Children's Health, which includes Lucile Packard Children's Hospital with about 360 beds and outpatient clinics across 65 locations in the Bay Area. Stanford Healthcare, which is our adult healthcare system, including a new hospital that was opened just about a year ago with about 600 beds. The two health systems have different instances of EPIC. So, and the information service teams are also separate. So we got to work with a diverse group of people to learn about operational informatics within these two health systems. The School of Medicine rotations gives us opportunity to learn more about research informatics. We also have a QI rotation. And finally, we have a clinical informatics console service rotation where we learn how to translate a clinical question into a database query to get some insights. And in addition to the co-rotation, we are allowed to do electives at other health systems or in the industry. And once we finish the co-rotations, then we spend the majority of our time in our longitudinal operational or scholarly projects. So with that said, I'm going to transition to let each of us introduce themselves and talk briefly about our scholarly work. So feel free to ask questions in the chat, and we'll be happy to address your questions at the end. So Amrita, I'll gonna let you give you control of the slide, and you can advance. Let me know if you.
Yes, I think I have it.
Awesome. All right, why don't you take it away?
Thank you so much. All right, hi, I'm Amrita, a combined pediatric critical care and clinical informatics fellow here at Stanford. My interests include clinical workflow optimization, clinical data standardization, and provider wellness. And I've had the opportunity to work on designing and implementing clinical informatics solutions as a part of several quality improvement projects in the PICU, as well as working on some scholarly projects. So the first project that I'm going to be talking about is clock metrics, which are non-proprietary measures of ambulatory EHR use associated with clinician work exhaustion. And I'm going to be going through relatively fast. Feel free to post questions and I can look at them and address them in a bit. So there is evidence indicating the association of EHR use after work hours after work hours with occupational distress, including burnout. An unintended consequence of EHR adoption in this study that I cannot go back for some reason, but there was a study that came out in 2020. Julia Adler-Milstein worked on it, and they showed an association between the top 2 quartiles of vendor-defined EHR use with greater odds of high exhaustion. However, vendor-defined EHR use measures often rely on confidential algorithms that do not provide transparency, which hinder interpretation and subsequent intervention. So our team here at Stanford developed and refined a non-proprietary EHR use algorithm to track the number of hours a physician spends logged into the EHR and calculates the clock time, which is the clinician logged in outside clinic time. In contrast to common vendor-defined use measures, the clock metrics take into account variation in physician schedules and thus make interpretation a little bit easier and better. All right. An earlier iteration of the clock metric was noted to be significantly correlated with self-reported time, and it was also significantly associated with satisfaction with workload in the EHR and satisfaction with subjective report of amount of time spent in the EHR after work hours. The objective of my study was to measure the association between clock metrics and validated measures of physician burnout and professional fulfillment. I apologize for the slides flipping back and forth like that. Do you mind taking control of the slides and I can just say next? I think that'll work better. There's a little bit of lag.
Yeah, sure. I'll help you drive.
Thank you so much. All right. Just going forward, our study was conducted at Stanford Healthcare and around 70 ambulatory practices across Northern California called the University Healthcare Alliance. We included 97 and 108 physicians from SHC and UHA who met our inclusion criteria, which are working in the listed outpatient departments, logging in more than 8 hours per week of clinic time, and answering the survey that was administered in fall 2019. And we collected clock metrics for a period of 3 months prior to survey administration. Next. So on average, we noted that physicians spent 12.3 clock hours per week with an average of 1.8 clock hours per week on weekends. The average clock ratio was noted to be 0.71, indicating that for every hour of allocated appointment time, physicians spent an additional 43 minutes logged into the EHR. Next. The average burnout score was noted to be 2.79, and the professional fulfillment score was 6.5. While 38% of physicians had high professional fulfillment, we noted 32% had symptoms of burnout. Next, please. A larger clock ratio was significantly associated with higher work exhaustion, consistent with association in recent literature. Can you click 3 times? There's an animation slide. Thank you. And although it is challenging to determine an ideal number of clock hours, given individual variation in EHR use patterns, documentation preferences, and schedules, our study suggests that a lower clock ratio may be more favorable, which could suggest that efforts to reduce clock ratio may be worthwhile and that it could be used as an improvement metric for efforts to tackle work exhaustion. Our finding that the physicians with larger clock ratios are not disengaged or burnt out, despite being exhausted, may be reflective of well-established personal resilience, resources, aiding self-efficacy, and other contributors. The magnitude of effect, as you can see here, was small, which may suggest that other aspects of EHR use and design may be more likely to be drivers of physician burnout than time spent on the EHR as such. Next, please. And our finding here of allocated appointment time, scheduled patient time, and with patient time, there are also metrics that we track with the clock algorithm, significantly associated, positively correlated with professional fulfillment is unexpected, as there's literature out there that associates work hours and burnout. Our results could be interpreted as having more time dedicated to clinical work in an academic medical center, being protective against work exhaustion, interpersonal disengagement, and overall burnout. Next, please. I have started working on a project focusing on the impact of COVID, the pandemic, on patterns of EHR use and clock time. Next, please. So this is my second study here, and it's titled Measuring the Relation Between Inpatient EHR Use and Provider Burnout. Next, please. So a little bit of background. We know that 25% of hospitalists and 50% of pediatric critical care physicians in the United States experience symptoms of burnout at any given time. It is known that EHR use is associated with a higher prevalence of burnout in the neonatal ICU, but the relationship between EHR use and burnout in other inpatient settings remains unclear. Next, please. The objectives of my study are to measure the relations between EHR experience and burnout, and to also identify objective EHR-based measures to identify those providers at an increased risk of burnout. Next, please. My study is being conducted at LPCH Stanford, attending physicians, fellow physicians, hospitalists, and APPs with more than 90% clinical time in the inpatient setting who respond to the wellness survey that was administered fall 2020 will be included in the study with an anticipated response rate of more than 75%. I hope to gather data on around 200 providers. Next, please. We are in the process of collecting EHR use and schedule data for a period of 12 weeks prior to the administration of the wellness survey. And I hope to collect data on total number of hours, the number of charts opened, notes and orders placed, average case mix index, and number of problems on problem list, and number of service hours as indicators of the provider's workload and the patient acuity. Next, please. I do have a data analysis plan in place. We'll be using mixed effects logistic regression for my AIM-1, and for AIM-2, I hope to construct a burnout prediction model to identify objective EHR experience measures independently associated with burnout. Next, please. As an initial step to my study, I sought to validate inpatient EHR audit log timestamp data using EHR usage screen recordings. Next, please. Next, please. Thank you. We included attending physicians, fellow physicians, hospitalists, and APPs at LPCH Stanford in the PICU setting, which is a 36-bed PICU, who at least had one clinical shift in the past 14 days and more than half FTE for the past month. Next, please. Login and logout timestamp data were collected from EHR's database and by direct observation of recorded EHR sessions on the session recording player, which is a tool to retrospectively review screen recordings captured as the provider interacts with the EHR. Total logged in time was calculated from audit log and observed EHR sessions. Additionally, we also collected active and inactive EHR times from the recorded EHR sessions. Inactive time was defined as the duration between the time at which a provider became inactive, that is no mouse or keyboard activity, leading to a lockout until the lockout screen appeared. And the active time was calculated by subtracting the inactive time from the total observed EHR time. Next, please. We collected data for 91 provider days, which includes 31 unique providers. Next, please. So my results so far. So we noted that median EHR times per provider day while they were on service was with a median of over 2 hours per day while on service. Active and inactive EHR use corresponded to a median of around an hour and a half and a half hour per provider day. Next, please. This graph depicts the observed EHR use by time of day among PICU providers with percentage calculations on the y-axis within each provider group type. We noted that EHR usage patterns varied among PICU provider groups through the day. Next, please. Despite this variation in EHR usage, we noted that audit log daily logged in times were within 15 minutes of observed logged in times for 84% of observations and within 30 minutes of observed EHR login times for 94% of observations. Next, please. And another click, thank you. And we also noted audit logs correlated strongly with both total observed logged in time and observed active EHR time. These are just beta coefficients, which can be interpreted as each minute of audit log time corresponding to 0.95 minutes of observed total logged in time and 0.75 minutes of active EHR time. Results were similar when stratified by provider role. Next, please. These findings support the use of EHR audit log data as a surrogate measure for inpatient provider EHR use. And these are some of the use cases: workflow improvement efforts to track outcomes of EHR training programs and for prediction of provider burnout. And I do plan on using EHR audit log data towards my second project. Thank you so much. I think those were all my slides. Apologize if I went through too fast. Looking at the chat right now. Please feel free to ask questions.
That's great. Amrita, you should definitely check out the chat. You got a bunch of shout outs and people recommending some other folks maybe you might want to get in touch with. So that's great. I'm gonna launch a quick poll here just because I'm curious to see what the crowd is all working on in regards to some of this burnout stuff. So it will pop up and be a little intrusive, but having said that, let's keep moving.
All right, great, thanks. I don't know how to turn on my video now that you gave me control. So sorry guys, just gonna be my voice now. So I'm an internal medicine physician, second-year clinical informatics fellow here. Thanks for giving me the opportunity to talk about my research. Today, I'm gonna talk about learning clinical decision thresholds. Ooh, cool, awesome. We or Ryan, whoever fixed that. Hey guys. All right, so today I'm going to talk about learning clinical decision thresholds for risk stratification models using real world evidence. So let's talk about situations where you might, all right, and then I think I just lost control of the screen. Oh, okay, no. So let's talk about situations where you might need to actually learn a decision threshold for a model. So we'll walk through this scenario together. You work for a hospital and lead the implementation of a machine learning model created by a vendor. An analyst comes to you and gives you this interactive report. So on the top left is a slider on this scale, and you get to choose a decision threshold. So this blue line moves between 0 and 1, and as you slide this number around, the other 3 cells of this table sort of change. And they're all giving you elements of predictive performance of this model. On the top right is the confusion matrix. On the bottom left are some of the same statistics now as numbers, as performance measures. And the bottom right is another graphical presentation called an ROC curve. And so you might have a good sense already based off of your subjective experience about what the disease is and what the intervention is, about what the right place that this decision threshold should be. But I wanted to talk about not objective ways of determining this decision threshold. So that's the focus of our work here. So if you look at the literature, one of the most common ways to come up with an objective decision threshold is to use a threshold model from medical decision analysis. So let's walk through this together. So the first thing that you'll do is go find utility values of the disease and the intervention that you're conducting. And so you might do experiments like time trade-off or standard gamble experiments to learn what people value about the outcomes. Or you might luck out and someone in the literature has already published this for you. You'll take the results of these studies and you'll make some assumptions about them in the second step. And so these assumptions have to do with how these harms and benefits relate to the probability of disease, which is represented on the x-axis here. And so on this graphical representation, we can see a place at about 11% of probability of a DVT, in this case, about where the decision threshold should be determined objectively. On the right side, you don't have to do this graphically. There's actually a formula that you can use a little bit of arithmetic to calculate this decision threshold. So you would input the utility values for harms and benefits, and you would come up with this P star, the decision threshold that you would use for your model. But this process actually has a drawback. Sorry, I clicked next slide, but it hasn't moved yet. I think you might have to take over again because I'm not sure if it's responding. Okay, there we go. If you don't mind, I'll just tell you next slide and we'll let you do it. So if one of the drawbacks of this process is that you can't calculate a threshold without utility values. So if you can't find the utility values, or if you're not lucky enough that someone else has already done that for you, then you can't go through this process and you can't find an objective decision threshold. So that's the motivation for my research. Next slide. So I wanted to think about, is there an alternative that you can use to help you decide what the decision threshold should be objectively? And I was really motivated by this, by how we practice medicine. So I was thinking, okay, when we're seeing patients in real life, we have this situation where we're evaluating them and we're ingesting their data. And in mind, we're going through this clinical reasoning process represented by the cloud bubble on the left. And we're thinking about benefits, preferences, harms, resource constraints, costs, and we're balancing sort of a hidden weight in our mind about whether or not we're going to act. And we decide, okay, this is a patient who might benefit from this treatment, so we act in real life and we prescribe something. Next slide. I wanted to see if we can flip this. So we can observe whether or not you act in real life, and we can perhaps use data about what you did to understand a little bit about your cloud, how the seesaw is shaped for you. So it's a latent variable. It's something that we can't directly observe, but I'm trying to experiment to learn if we can understand how you balance things based off of your actions. So that's a motivation for our work, and we're going to walk through a procedure to do that. So next slide. So I gathered data from Stanford. So from Stanford Medicine, we have primary care patients that we evaluate for coronary vascular disease risk. And over the past 10 years, I was able to extract a cohort where about 28,000 patients were evaluated with lipids and didn't already have coronary disease. And we could extract from our EHR how many of those patients were prescribed a statin. So about 80% were not prescribed a statin and 20% were. Next slide. we use this data to calculate for each of those patients what their pooled cohort equation risk score is. So on the x-axis here, I've calculated each patient's risk score, and we've bundled them to the nearest percentage point of pooled cohort equation risk. On the y-axis, we've lumped together for all the patients who have similar risk scores, what percentage of them were prescribed a statin in our cohort. So next slide. For example, of patients who had 15% risk, about 40%, 4 out of 10 of them were prescribed a statin by our physicians. One of the cool things about this graph is that you can see a very nice pattern forming, especially early on in the lower risk score categories, about a relationship between the risk of the patient to have an outcome and the likelihood of us treating. And so the next step that we want to do is see if we can model this data. Next slide. We use some of the same assumptions made by medical decision analysis to help us fit a model. So the underlying principle is that you're likely to treat a patient if their benefits from that treatment outweigh the harms. It's a very standard pattern that we use in making medical decisions, right? We use some of these same assumptions by decision analysis. On the second line, the utility of benefits are proportional to some coefficient of benefit times the probability of their disease. That's one of the fundamental assumptions made by decision analysis. In this example, we know that that has reasonable face validity because there are well-done studies and well-done meta-analyses that show that statins have a 20% reduction in major adverse cardiovascular events. And we have a good way of measuring sort of the probability of disease represented by the pooled cohort equation score. So we'll compose these, this utility theory version of medical decision-making with our data using the equation at the bottom. So this says that our probability to treat is related to some coefficients and a factor, including our prediction from the pooled cohort equations that represent the utility benefits and also our utility harms. And we fit that model to our data on the right. And we actually find that it's a good representation of decision-making in real life, which is an accomplishment in its own right. It's pretty interesting to see that we can actually mathematically model decision-making of physicians using EHR data. But we need to go back to our original problem, which is that our analysts gave us this report and we have to decide where our decision threshold is. So we got to figure out where on the x-axis we're gonna set our markers. So next slide. And we'll use important anchors on the y-axis to help us decide that. So this is the majority vote line, so where the y-axis is 50%. And we solve our equation for what risk score is equal to that. In this case, it's 23.6%. Next slide. We can also find a second decision threshold, what we call the popular vote. So that's where the population on average has been prescribed treatment, 21% in this case. And we also solve this equation for pooled cohort equations. And that's 3.9%. And next slide, and I think I'm going to get to Matt's comments. So we then take those decision thresholds, we map them onto the ROC curve. And for reference here, I've actually plotted the thresholds in the guidelines of the 5, 7.5, and 20%, just to give you some visual reference. But I also want to comment that the blue dot, the 3.9% figure, is actually very consistent with a well-done cost-effectiveness analysis published in JAMA that actually said that patients would actually benefit starting at that level. And our physicians are showing us that they're starting to prescribe at that level. Whereas the red dot, the one above 20%, our RCT data shows that patients actually have really well documented benefits from statins. So we're also observing that, of course, at that level, most patients are being prescribed statins. So it's a really nice way of using data. Next slide. That helps us understand how physicians in real life balanced harms, benefits, preferences, costs to decide when they were going to treat. We can use that data to help us set a point on the operating point, this dashboard that we need to do so that we can inform our data analysts how we should be implementing our risk stratification models. So that's it. I think acknowledgements are at the end, and then we can keep moving. Thanks, guys.
Hi guys, my name is Sana. I'm an OBGYN and I'm an MFM and Clinical Informatics Fellow. Okay, I'll let you know if I need you to take over again.
Yeah, just give you control and see if that works.
Okay, sounds good. All right, so I've spent my fellowship really focusing on, okay, I'm not sure it's letting me advance. Are you advancing, Wei, or is that me?
No, it's you. I didn't touch anything.
Huh, okay. It seems to be sort of spazzing out a little bit. I think because of the lag. Are you okay holding on to control?
Sure. Yeah, I can drive.
Thanks. All right, sorry about that, guys. So I have been focusing my fellowship on just the bridge between informatics and women's health. There's relatively few OBGYNs who have completed clinical informatics fellowship, although there are many more who are interested in the field and maybe doing work on it without being aware that it is a field. So I've spent a fair bit of time just connecting with other OBGYNs, and if you have any OBGYNs in your fellowship or in your institution who are interested, I'd love to connect with them. So, all right, I'm gonna spend a little bit of time talking about two of my projects. Next slide. So the first one is a study on the use of a chatbot for postpartum mental health. Go next. And one more. Okay, so we conducted an RCT looking at one of the automated conversational agents that's available commercially, specifically on a postpartum population. Next. Okay, so when we think about AI use in healthcare, I think all of us are aware of the potential benefits of using AI for mental health. The general population is open to this. About 70% of patients showed an interest in using mobile apps to manage their mental health. And as telemedicine expands, we think about chatbots specifically as a tool that we can use because of the significant provider time required for psychotherapy. If any of the diagnosis or psychotherapy can be done by AI, that can really relieve some of the burden of taking care of these patients because the scale is infinite in a sense. So this is a framework for thinking about how AI can contribute to psychotherapy. So at the top you have humans only. This is our current situation, or at least was until relatively recently. Obviously there's limited access, but we know the quality of the psychotherapy is established and the clinician-patient relationship is established as well. And then as you go down, there's a spectrum of being AI informed or AI delivered care that's human supervised, and finally AI only psychotherapy. So the scalability and the access to care will improve over time, but there's a lot of unknowns about the quality of care or the relationship between AI and the patient in these new settings. So I think when we think about these technologies, obviously there's a lot of pros, but there's also some risks. You know, there's risk related to privacy, to bias and how these AI models are developed, coercion, and then liability. Where does the liability land if there's not a physician behind the psychotherapy? So we wanted to study this a little bit further. You can go to the next slide. All right, so in thinking about chatbots, there's one such bot that was created with Stanford physicians, and it's commercially available. It provides cognitive behavioral therapy through daily mood tracking, interactive chats, and personalized videos and exercises. So here are some examples of different chats with this chatbot. And we wanted to assess whether this technology could help bridge the gap with tools that are appropriate for postpartum patients specifically. Okay, next slide. One more, thanks. So about half of all women report some increase in anxiety and depression symptoms, either during pregnancy or postpartum. Postpartum depression itself is a clinical diagnosis, and approximately 8 to 12% of women will experience the full this full range of clinical depression. But again, it's very likely underdiagnosed. Can we advance again? And only about 1 in 5 women will actually report their symptoms to their provider. So this is definitely a disease process that women need to be screened for. Otherwise, we're going to miss a significant number of women. Okay, Next. So our study objective was to evaluate whether a chatbot was an effective and acceptable mood management tool in the postpartum setting. Next. Okay, so because this was a relatively new technology, especially in this setting, we started with a preliminary study looking at the general postpartum population rather than recruiting women who were depressed at baseline. We wanted to establish that this was efficacious, but also it was safe and feasible. We recruited participants who had a smartphone that were English speaking, since the chatbot converses in English, were at least 18 years old and had delivered a live baby. We consented patients during their birth hospitalization, so women were anywhere between 1 and 3 days postpartum, and randomized them at that time. Next slide. All right, so all participants completed baseline surveys. We used a few different mental health assessment tools. The OB-specific one is the EPDS that looks for specific symptoms of postnatal depression. And we use a general PHQ-9 and GAD-7, which are common screening tools for depression and anxiety, respectively. We followed up with people every 2, 4, and 6 weeks. And then those who are in the treatment group, so in the chatbot group, we also asked them about how often they were logging on and whether they found it acceptable and whether they were satisfied or felt connected to the chatbot. And they were just told to use the chatbot as freely as they wanted to.
Oh, wow.
Next slide. So looking at our population, the baseline characteristics between the two groups were similar. The mean age was 34. The majority of participants were white or Asian, employed and married. Some had pre-existing medical conditions, but relatively few. But many more were currently or previously had psychotherapy. And notably, 80% of women, if you advance one more slide, thanks. 80% of women in both groups were comfortable with the use of a mobile app to manage mood. So this was a higher number than we were expecting, I think reflecting the Bay Area population. All right, next slide. In looking at our primary outcome, we saw that depression scores decreased more in the chatbot group than in the control group. This was only slightly statistically significant, and I think notably all the scores were below the screening thresholds of 5, 10, and 15 for mild, moderate, or severe depression. So at baseline, women did not have a lot of symptoms in this group. All right, next. In looking at chatbot usage, you can advance again, thanks. About 74% reported using the chatbot at least once. And you can double click for the next couple slides. Acceptability, majority found that the chatbot was acceptable. And next slide. Majority found that the chatbot was satisfactory. So high satisfaction, median satisfaction was also quite high. So I think our conclusion from this study, next slide, just showing that the use of a mental health chatbot among a general postpartum population did slightly decrease depression scores compared to controls. But more importantly, that participants had a high satisfaction with this chatbot and found it acceptable. There were specific comments about people feeling like they actually really connected with the chatbot and felt that the chatbot cared for them, using different tools that we use to assess the bond between a therapist and a patient. So I think it was really interesting to see how patients can develop a relationship. All right, I'll just pause for a second to mention some of the comments before we move on to the next project. I see a comment from Ryan about broadening the availability of this tool. Yeah, that's a great question, Ryan. I know that the chatbot is actually, now a third-party company. They've split off from Stanford, and they're definitely assessing this. I'm not sure how far they've gotten, but I think at least they're wanting to make this available in Spanish at a minimum, and then thinking about limited tech literacy patients is something that they're exploring. I think the smartphone and messaging-based system they found that was compatible, obviously, with a lot of different smartphone applications, but the tech literacy and the availability is something they've really been thinking about, especially when it comes to things like data usage, et cetera. And one other comment, are the study participants informed ahead of time about the limitations? Yeah, that's a great a great point. We did talk to participants briefly about the limitations of the chatbot, but I think one of the features I really liked is that the onboarding is really comprehensive. So when you download the bot and begin the conversations, it goes through, you know, the fact that this is not human supervised. So no one is actually reading these comments, which obviously for some participants, that's a positive thing. For other participants, that can be scary, especially if this is the first time. So it also goes through some crisis language. The bot can detect certain types of words. I think there's like 300 different words or combination of words that can alert the bot to a crisis. And they basically will say, like, it sounds like you're in a crisis. These are the resources you have. Again, this bot is not going to call your doctor or connect you to anyone. And so it's really the participant's responsibility to, you know, access those resources. So obviously this is one piece of a puzzle, but there needs to be a whole infrastructure for caring for patients, especially those who are, you know, in acute crises. Okay. And one question about if folks are not told they'll be talking to a chatbot, will they still use the service? That's a good question. I think here we were very open about that. I'm not sure about a study where we were would not disclose that they were talking to a chatbot. I can imagine we had a lot of trouble getting through our IRB. I can imagine that would be a really difficult conversation with the IRB as well. All right, moving on. I just want to spend a few minutes talking about one other project. Okay, so the next one is a landscape of telemedicine use in high-risk obstetrics. Next slide. So this is related to the current pandemic. We wanted to understand the usage and perceptions of telehealth among high-risk OB providers. Next slide. We surveyed the Society of Maternal Fetal Medicine, the membership there, and just assessed basic demographics, EHR usage, telemedicine usage, and specifically we wanted to understand the different use cases and remote monitoring modalities and perceptions. So this survey just closed a few days ago, so we just have some preliminary results I'd love to share. Okay, next slide. So we had 422 total respondents. They were primarily in a university setting. The majority were in an urban environment. And the mean age was 48 with a mean number of providers and a practice of 9. I think that also reflects that this is primarily a university hospital, as many other MFMs might be, you know, have fewer providers in their practices, especially in the rural areas. The majority of respondents here cared for patients covered by Medicaid insurance. So during pregnancy, there is I wouldn't say universal, but near universal access to insurance and through Medicaid. All right, next slide. So as expected, we can see that the use of telehealth increased across all modalities during the pandemic. There was much larger jumps in telephone visits and live video visits, and some increase in remote monitoring, other things like physician-to-physician consultations or patient care, patient portal and remote ultrasound imaging had a smaller increase. Next slide. Prior to the pandemic, the majority of participants did not perform any live video visits. So this was, you know, more than half of our population hadn't done live video visits before the start of the pandemic. So it really reflects a rapid shift during the pandemic. Next slide. And the specific remote monitoring tools that increased during the pandemic, specifically blood pressure monitors. We also saw an increase in oxygen saturation monitors, thermometers, and smaller increases in things like scales, heart rate monitors, and glucometers. Next slide. And the different use cases for telehealth before the pandemic versus after, I think we see, you know, across all use cases, telehealth increased significantly. So whether someone was providing all of the prenatal care for a patient or just one-time consultations, there was an increase across the board. Next slide. And we wanted to assess reimbursement and also see if that changed based on the state. So the state-by-state analyses we're still working on, but in general, we see that telehealth visits by video were more likely to be reimbursed at the same rate than telephone visits were. Next slide. And when we looked at specific telehealth platforms, there was a lot of variation. So the Epic Zoom integration was the most commonly used one, but there were many, many other platforms that were specified. Video, Doxy.me, but you can see the other list here is broad on the right-hand side. And I think this is also evolving. We spoke to some who have used 2 or 3 different platforms already. All right, that was very brief. I want to give Lee time to talk about his projects as well, but feel free to reach out and I'll look at the chat and respond to questions there. Thank you, guys.
So hi, everyone. I'm just going to spend the last 10 minutes to talk about a little bit about my project. So my project is about developing a recommender algorithm for initial workup when a patient is being referred for specialists. So just a little bit of background. Many of you know access to subspecialists in general is limited. The typical wait time, for appointments are weeks to months. The problem is that even when patients finally get to see a specialist, their first visit oftentimes could be wasted because many of them do not come with appropriate pre-workup such that the specialist could not make any concrete recommendation at their first visit. A study done in the adult endocrine clinic shows that only about a quarter of the referral contain all essential data that the specialists need. In the pediatric space, I could not find similar data from the literature, so I did a survey with our pediatric endocrinologists at Stanford. The reason I'm interested in endocrine because many of their patients need lab work prior to their first visit. So we have 14 endocrinologists at Stanford Children's, 12 of them responded to the survey. So we asked them 3 common conditions for referral: abnormal thyroid studies, obesity, and amenorrhea. We asked them to estimate what percentage of their patients with appropriate pre-workup completed before their first visit. As you can see in the table, only less than half of the patients come with appropriate pre-workup. So the question is, how can primary care doctor help patients to get the appropriate initial workup when they refer a patient? So the first thing you could do is call your specialist. However, everyone knows that clinicians are busy. This probably is not practical. And in fact, studies have shown that PCP were only able to communicate specialists half of the time when they make a new referral. Another approach is to establish a consensus guideline for referral workup between primary care doctors and specialists. And people have done that. This study was done at UCSF regarding adult GI specialty care, where they try to build consensus using the Delphi method. However, the entire process took 3 months, which is very time consuming. And keep in mind that this is only one specialty at one institution. What about e-consult? Well, the process is still asynchronous, and the lag time is usually 1 to 2 business days, and it still requires the availability of a specialist to answer those questions. The question is, can we do better? What if we build a real-time recommendation system to give recommendations for initial workup whenever primary care doctors refer a patient to a specialist? And many of us have used commercial recommendation system like Amazon or Netflix. If you order item A, the system will predict you will like item B as well. And this kind of system is highly scalable. So it turns out we can use a similar approach in the EHR, where you can think of patients are analogous to customers, and items in the EHR like diagnosis code, labs, medications, imaging orders are analogous to items in a product catalog, and the item instances are analogous to items actually purchased by a customer. So how do we actually develop the algorithm? So first step, I use SQL query to construct the cohort of a study. So we, again, pediatric patients with endocrine referral orders that was placed from primary care clinics, and these patients have a subsequent endocrine visit within a year, and the study period is from 2015 to 2019, and we have a training set and a test set. And here's the result of the data pool. We have about 1,300 patients who met criteria. We have a couple thousand distinct clinical items and about 180,000 instances. So to organize these clinical items, the first things that I do is to construct a patient timeline object. In our case, there are two important time points. The first one is the primary care visits, where an endocrine referral is made. The second time point is the first endocrine visit. As you can see in the diagram, so essentially we use clinical items like diagnoses, labs, medications within the 6 months of the primary care visits to try to predict the lab and imaging orders at the first endocrine visits. And how do we train the algorithm? The first thing we need to do is to build an item co-occurrence matrix. Remember that each timeline represents a patient, and we have multiple patients in our training sets. And for each clinical items that are associated with the primary care visits, you put them on one side of this matrix. And for items that are associated with the first endocrine visits, you put them on the other side, like the columns here. If you have a patient has item A at the primary care visit, followed by item B at the endocrine visits, in matrix row A and column B, you will add 1 for each patient that you observe this pattern. So using this matrix, the next question is, how can you generate a list of recommended items in your test data? So you start with a list of candidate items from your matrix. And first, you can calculate the pretest probability of the candidate item B, which is simply the prevalence of item B in your cohort. Then given the query item A, you can calculate the post-test probability by counting the number of patients who have item A, then followed by candidate item B, this NAB term, and divided by the number of items A. And this is your post-test probability, or positive predictive value, PPV. And remember, you can get this NA term exactly from the co-occurrence matrix from the training data. And if you have multiple query items, this is the formula to aggregate the results with an optional weighting factor where you can weigh and query items based on how relevant it is to the specialty. And here's the results of the test data, the algorithm performance. The first plot is AUC, and the second and third plot are precision and recall with 5 items recommendation. And the reason we choose 5 is that's because that's the average number of workup orders at the endocrine clinic. The first row is just a sanity check using random ranking. The second is using the pretest probability, which is the prevalence of an item in all outpatient cohort. The third is using the prevalence of an item in our endocrine referral cohort. And you already see it gives pretty good performance. And once we use the recommender algorithm that is based on the post-test probability, PPV, you see further improvement, and the weighted algorithm did the best with an AUC of about 0.92. Now, a typical concern for using recommender algorithm in clinical setting is that how can you know these crowdsourcing results are clinically appropriate? And we did validation of the algorithm output, again, with the help of our endocrinologist colleagues. Remember, we surveyed the 3 common referral reasons. And for each reason, we essentially run the recommender algorithm using a single query item just for simplicity of evaluation. For example, for abnormal thyroid studies, we can query with either high TSH or low TSH. And for obesity and amenorrhea, we use the diagnosis. And then we got 4 resulting lists of workup orders in each of these conditions. And then we asked the endocrinologist whether the list of those orders are appropriate for as initial workup. And because of time, I'm only showing just one of this list of the survey results. And this query is based on lab result of high TSH. The first column you see here is the top recommended orders like TSH, 3T4. And if you look at the second to the last column here, you can see vast majority of the specialists agree with the top 4 orders. And we also did a literature review to see if these orders are reasonable and find that they're consistent with the specialists. So in summary, I show you that initial workup is completed usually less than half of the time, where at least for common referral reason in for endocrinology. And we developed a recommender algorithm that could predict a specialist workup order. And based on a survey result, it looks like the top recommended orders clinically appropriate, at least for their 3 referral reasons that we survey. And we think that this type of algorithm can potentially serve as a clinical decision support tool for outpatient specialty referral. And yeah, the next step is to thinking about how we can actually implement this type of algorithm and do further validation. And yeah, and this acknowledgement, I would love to, and yeah, I think we are almost at time, but we'll see. You guys have any questions for any of us?
Yeah, boy, you guys are doing awesome work. This has been really, really insightful. I am like frantically writing notes and messaging my co-fellows about stuff that I want to do. So hats off to you guys. You're doing awesome stuff, and thank you very much for sharing. You know, there's a lot of good stuff in the comments. Some people trying to connect folks. This is great. I think this is one of the core purposes of having these conferences, is that this isn't a huge network, and so the more we can connect with each other and learn what each other is doing, I think the better. So with that, I do want to make sure if anybody's got comments or questions and they want to unmute, by all means, jump on in. Not all at once, guys. That's okay if we don't have questions too. I do have a question for, are you thinking of expanding this? I'm sorry if I missed it. I was trying to write some other notes, but are you thinking of expanding this outside of endocrine? And if so, what would be the next department? And did you have any sort of systematic way of picking those departments based on like data that would show the initial referral appointment followed by another appointment shortly thereafter, or how did you assign those?
Yeah, I think that's a great question. So, so currently we just thinking in from a clinical perspective, we're just thinking of those like kind of lab heavy specialty, right? Endocrinologists, I think hematology could be another one. But you made a great point. Potentially, we could use look into the EHR data and see, you know, as a system, do we have any? Can we calculate, you know, which of these first visits are actually wasted? They have to, you know, come back within very quickly once they got labs. I think that's a great point.
Yeah, that's something I've never thought about before. This is a great idea, and I hope you guys keep running with it. So we are over time. If anybody, I'll leave this open. I'll stop recording. I'll leave the chat open for a while if anybody wants to jump in. But thank you, all 4 of you, so much. This has been really informative and just great to see all the awesome work you guys are doing at Stanford. So thank you.
Yeah, thank you for everyone joining.
Yeah, of course. It's everybody out there who's able to join us. Thank you, and have a great weekend.
Thanks.